Hello, everybody. Tonight we are doing AHIP Module 3. Can you believe it? We're almost halfway done. When we finish tonight, we will be more than halfway done. Thank you all for joining in live. And if you miss any part or if you need to refresh or go back, the recordings are up on my YouTube channel. So you can go there and look for 2026 AHIP modules. Tonight we're doing, as I said, module 3. Okay, can everybody see my screen? Let me make sure that everybody that's with me is
Yes.
awake. Everybody can see the screen. We've done module 1, we've done module 2, we've got the check marks there. Thank you, Frazier. And we're going into module 3, which is Medicare Part D prescription drug coverage. After completing this module, we should all be able to explain all of the Part D prescription drug programs, the standalone plan, the Medicare Advantage plan with prescription drugs. We should understand Medicare Part D eligibility rules, be able to identify Medicare beneficiaries who may enroll in a standalone prescription drug plan, obtain basic information about drug formularies and the use of tiering and benefit structures. We will review what drugs are covered under Part D and what drugs are not covered. Learn about Part D standard and alternative benefits. List standard benefit out-of-pocket costs, including deductibles and cost sharing for both generic and brand name drugs. We should be able to explain the term true out-of-pocket costs and what counts towards that cost. And how do you move into the threshold of the catastrophic coverage? We should be able to describe what happens once a Part D beneficiary outlay reaches that catastrophic limit. We'll gain knowledge about pharmacy networks and their roles in the Part D plan. We'll be able to explain Part D premiums and the way those premiums are paid. We can also identify what is the Part D late enrollment penalty. We'll also be able to gain a basic understanding of Part D assistance programs, how to file grievances about a Part D plan or about a pharmacy, how we might be able to help individuals with limited income, how does pharmaceutical assistance programs work, understand the importance of credible coverage for those with employer or union prescription drug coverage, learn about the interplay between Medicaid and Medicare regarding Part D coverage, gain a basic understanding of Medicare drug price negotiation programs, the capping of the out-of-pocket cost for beneficiaries at $2,000, and the new Medicare prescription payment plan. Each module has these instructions at the beginning. O1 to go back, O2, the blue one, to take a note. And don't forget that always up in the upper left-hand corner of the screen, you're able to download slides for that particular module. So that's a constant in every one of the modules. The terms and conditions are the same in every module. Of course, this information is copyrighted. We can't change it. It is what it is. So you're learning, there are 5 learning objectives for Module 3. What Part D plans are and who's eligible to enroll. Part D standard and alternate benefits, management tools, covered drugs, and formulary requirements. Part D true out-of-pocket or troop costs and help for beneficiaries with limited income. Late enrollment penalties and premiums, and the Medicare prescription payment plan. Our roadmap looks like this: Medicare Part D basics and eligibility, covered drugs, Part D standard and alternative benefits, the true out-of-pocket costs, Part D premiums, late enrollment penalties, Part D drug management tools and formulary requirements, Medicare prescription drug payment plan, Part D enrollee rights, Part D assistance programs, Part D and other coverage. These are changes for 2026. So it is important that you pay attention to this segment. They're letting us know that these are definitely changes for 2026. As part of the Inflation Reduction Act, Congress made several changes to the Part D program, including elimination of the coverage gap and capping out-of-pocket costs. The Inflation Reduction Act changes that will be implemented for the first time in 2026 are further addressed in this training, and they include negotiated pricing will apply to certain drugs selected for the Medicare price negotiation program. The Inflation Reduction Act provided Medicare the ability to directly negotiate the prices of certain high expenditure single source drugs without generic or biosimilar competitions. CMS selected 10 drugs covered under Medicare Part D for the first cycle of negotiations for initial price applicability year 2026. During the initial coverage phase, CMS will pay Part D plans a subsidy of 10% of drugs selected for price negotiations during the price applicability period. During the catastrophic phase, CMS will pay Part D plans 40% reinsurance for drugs selected for price negotiations during the price applicability period. The CMS subsidy and reinsurance changes do not impact beneficiary cost-sharing percentages, which were substantially reduced beginning in the plan year 2025 by elimination of the coverage gap and capping the out-of-pocket cost. However, they will affect the price of negotiated drugs. So in a nutshell, there are 10 drugs that were chosen at the end of 2024 by CMS to be negotiated, and those prices will be much lower. And they're going to be drugs like, if I remember the list that I saw As an example, and you all will recognize this one, I think Eloquist is one of the ones that's on that list. But I don't know the list, but I just wanted to give you an example. You know the cost of Eloquist now. You know that it's probably a tier 3. So if that's one of the ones that the prices have been negotiated, then it's going to have a lower out-of-pocket cost overall in 2026. Medicare Part D prescription drug program basics. Medicare Part D covers certain prescription drugs, diabetic supplies, and vaccines. Coverage of Medicare Part D benefits is provided only through private companies. There is no fee-for-service Part D benefit. The types of Medicare plans that include Part D benefits are standalone prescription drug plans, Medicare Advantage prescription drug plans. Those are Medicare Advantage plans with prescription drugs included. Cost prescription drug plans are Medicare cost plans that cover Part D prescription as an optional supplemental benefit, and PACE plans. Those are the 4 types of Medicare plans that include Part D benefits. To be eligible for Part D, individuals must be entitled to Part A and or enrolled under Part B, not including enrollment in Part B solely for coverage of immunosuppressive drugs. And they must also be a United States citizen or lawfully present in the United States on or before the enrollment effective date. Individuals meeting this criteria are generally eligible to obtain Part D benefits through any prescription drug plan offered in the area in which the individual permanently lives, depending on how they receive Medicare benefits. The prescription drug plan must enroll any eligible beneficiary who applies regardless of their health status. To obtain a Part D benefit from other types of Medicare health plans, such as an MAPD, Medicare cost plan, or PACE plan, the individual will have to meet the additional eligibility criteria for those plans. For example, to enroll in a Medicare Advantage plan, individuals must be entitled to both Medicare Part A and enrolled in Part B. Eligibility to enroll in a standalone prescription drug plan depends on how the individual receives their medical benefits under Medicare. Generally, only those beneficiaries who are enrolled in original Medicare, those who are enrolled in a Medicare Advantage, Medicare Savings account, those who have a Medicare Advantage private fee-for-service plan or a cost plan may enroll in a standalone Part D prescription drug plan. Beneficiaries enrolled in a Medicare Advantage Medicare Savings account may only obtain Part D benefits through the standalone prescription drug plan. Enrollees enrolled in a cost plan or a private fee-for-service plan may obtain Part D benefits through the plan if it's offered in the plan or through a standalone prescription drug plan. Beneficiaries enrolled in an HMO or a PPO may only obtain Part D benefits through the HMO or the PPO plan. In some cases, employer group plan enrollees may have additional choices. Individuals enrolled in a PACE plan may only receive their Part D benefits through their plan. Ms. Foley has just become eligible for Medicare. However, she's not eligible for premium free Part A. She has chosen not to pay the premium to obtain Part A, but will enroll in Part B. She asked her broker whether she can get coverage for her prescription drugs as well. Her broker correctly advises her that she's eligible to enroll in Part D and may choose among the freestanding prescription drug plans available in the area where she lives. Mr. Page has original Medicare and gets his Part D coverage through a standalone prescription drug plan. During the annual election period, he wishes to enroll in a Medicare Advantage HMO to take advantage of a broad range of supplemental benefits. His broker correctly advises Mr. Page that if he chooses an HMO, he may no longer get his Part D benefits through a standalone prescription drug plan and must choose a plan through the HMO that includes Part D benefits if he wishes to maintain drug coverage. Covered Part D drugs. Part D plans cover prescription drugs, biologics, and biologics are drugs made from natural sources, human, animal, or microorganism that are not chemically sensitized. Examples include allergy shots and gene therapies. Prescription drugs Part D plans also cover insulin. They cover medical supplies associated with the injection of insulin, like syringes, needles, alcohol swabs, and gauze, and inhalation chambers, where insulin that's delivered through inhalation chambers. Prescription drug plans also cover vaccines not covered by Part B, for example, shingles, respiratory syncytial virus, RSV, and tetanus, diphtheria, whooping cough. The following drugs are excluded from the definition of a Part D covered drug. Prescription drug plans do not cover drugs for weight loss or gain, fertility, cosmetic purposes, symptomatic relief of cough and colds. The Part D plans do not cover vitamins, prescription vitamins, and minerals, with the exceptions of prenatal vitamins and fluoride preparations for certain uncommon vitamin D analogs. It does not cover medical foods formulated to be consumed or administered enterally under the supervision of a physician that are not regulated as drugs under Section 505 of the Food and Drug and Cosmetic Act. It does not cover erectile dysfunction drugs when they're used for sexual dysfunction. It does not cover any non-prescription drugs, does not cover some off-label use drugs, and does not cover drugs covered under Part A and B, even if an individual does not have such coverage. Part D plans are permitted to offer supplemental benefits that cover drugs that otherwise meet the definition of a Part D prescription drug, but are explicitly excluded from coverage, such as certain prescribed weight loss drugs. Part D plans generally do not cover all drugs available in each category of Part D covered drugs because in some cases, several similar drugs are available to treat the same medical condition. Part D plans include the Part D drugs that they will cover on a list known as a formulary. Formularies are developed by pharmacists, doctors, and other experts. Part D plan formularies must include at least 2 drugs in each therapeutic category. It must include generic and brand name drugs. And the formulary, all or substantially all so-called protected class drugs must be included as well. Each Part D covered drug selected for Medicare price negotiations for the period in which the negotiated maximum fair price is in effect. The Part D plan may remove the selected drug if certain requirements are met, including but not limited to replacing it with a generic version of a brand name drug that was not available on the market when the plan submitted its formulary. These are the 6 protected classes of drugs. These 6 protected classes are categories of drugs that treat life-changing or life-sustaining conditions. Antidepressants, antipsychotics, anticonvulsants, immunosuppressants for prophylaxis of organ transplant rejection, antiretrovirals, and anti-neoplastics. So there are 6, 5 of them start with anti, and the other one is immunosuppressive. For covered drugs and the tiering, a common feature of the Part D benefit structure and formulary is cost-sharing tiers. Tiered cost-sharing means grouping Part D drugs into different cost-sharing levels within a Part D sponsor's formulary. Many plans group drugs into 3 or 4 tiers, with lower tiers requiring less beneficiary cost sharing than the higher tiers. For example, tier 1 might be generic drugs, tier 2 would be maybe preferred brand name drugs, tier 3 non-preferred brand name drugs, tier 4 high cost drugs or specialty drugs. In evaluating whether a Part D plan should be recommended to a beneficiary, it is important to confirm not only that the beneficiary's drugs are on the formulary, but to also evaluate which cost-sharing tier the drug falls into. Part D plan benefits. All Part D plan benefits must cover at least the Part D standard benefit or meet the requirements for alternative benefits. Benefit structures that are not standard, but instead are actuarially equivalent are known as alternative coverage. So alternative coverage are those benefit structures that are not standard, but are actuarially equivalent. The standard benefit structure includes several coverage phases, including a deductible, an initial coverage phase between the deductible and the annual out-of-pocket threshold, a catastrophic coverage phase that applies after the beneficiary reaches the annual out-of-pocket threshold. Alternative coverage is prescription drug coverage that is not standard, but is at least actuarially equivalent to standard drug coverage. Actuarial equivalent means that the value of Part D benefits must be at least the same as the standard coverage. Alternative coverage must also not have an annual deductible that exceeds the annual deductible under the standard benefit. It must also impose a cost sharing once the annual out-of-pocket threshold is met. Alternative benefits may also be structured with some or all of the coverage phases that are part of standard benefits. Some Part D plans may offer enhanced coverage for an additional monthly premium known as enhanced alternative benefits. Coverage enhancements may include, for example, a reduction of the deductible, including a waiver of the deductible for a subset of formulary tiers, coverage of excluded drugs, and or a decrease in the beneficiary coinsurance amount in the initial coverage phase. This is the standard Part D benefit for 2026. For 2026, the standard benefit requires the beneficiary to pay 25% of prescription drug costs during the initial phase with a $615 deductible. Once the beneficiary out-of-pocket cost reaches a total of $2,100, the beneficiary is through the initial coverage phase and into the catastrophic coverage. Most of the plans that you see do not have that 25% in the first initial phase. It will have copays based on the tiers, but some plans will have the deductible and it could be $615 or less. As long as it is at least $615, it meets the standard, but the companies may have less of a deductible. The out-of-pocket costs that count towards reaching the catastrophic limit are known as true out-of-pocket costs or TROOP. For some instances, amounts not directly paid by the beneficiary count towards the TROOP. After reaching the annual out-of-pocket threshold, the beneficiary pays nothing. So this is what the standard billing benefit looks like in an illustration. Starting from the bottom and going up. First, they would have the deductible, $615. Then they're in the initial coverage phase, where the enrollee will pay no more than 25% of the cost of the drugs until the true out-of-pocket cost comes to $2,100. Then they're in the catastrophic coverage phase, where the enrollee pays $0. Special cost sharing for insulin and vaccines. There's no cost sharing for Part D adult vaccines recommended by the Advisory Committee on Immunization Practices, ACIP, by in-network or out-of-network providers, even in the deductible phase. This includes, but is not limited to, vaccines for shingles vaccines, tetanus, diphtheria, and pertussis, whooping cough, or RSV. The cost sharing for a 1-month supply of a covered insulin product cannot be more than $35. CMS plan and manufacturer payments for drugs. During the initial coverage phase, the Part D sponsor typically pays 65% for applicable drugs and drugs selected for negotiation, and 75% of the cost for all other Part D covered drugs. The manufacturer, through the manufacturer discount program, typically pays 10% of the cost of applicable drugs. CMS pays a subsidy of 10% of the drug's negotiated price for selected drugs during the period when the negotiated price applies. During the catastrophic phase, the Part D sponsor typically pays 60%, the manufacturer pays 20%, and CMS pays a reinsurance subsidy of 20% for all applicable drugs and 40% for all other Part D covered drugs during a price applicability period. True out-of-pocket costs. What counts and what doesn't count? The true out-of-pocket costs are out-of-pocket costs that counts towards the annual out-of-pocket threshold to move the individual into the catastrophic phase. So what counts? It's calculated on an annual basis, includes beneficiary payments for Part D prescription drugs, including the deductible, the cost sharing above the deductible up to the annual out-of-pocket threshold, and generally for drug costs that count towards TROOP, drugs must be on the plan's formulary and be purchased at the Part D plan's participating network pharmacy. That's important. The following also counts towards TROOP. Amounts paid are borne by the AIDS Drug Assistance Program and the Indian Health Service. Amounts paid by or through qualified state pharmaceutical programs, most charities, health savings account, flexible spending accounts, and medical savings accounts. Supplemental Part D coverage provided by enhanced alternative Part D plans and other health insurance. This includes supplemental coverage provided by employer group waiver plans, as well as Medicare plan reductions in cost sharing for enroll such beneficiaries, such as reductions by DSNPs. Included in TROOP is a Medicare prescription payment plan participants' eligible costs that are paid by their Part D plan under the Medicare prescription payment plan. Example 1, this is an example of true cost. Let me go back because I think we need to look at what is excluded. Okay. These are the things that are excluded from the TROOP. Some costs do not count towards TROOP. Costs for drugs that are not on the plan's formulary, unless the beneficiary requests and receive a formulary exception. Costs for over-the-counter drugs and other non-Part D drugs are not included. Costs for covered Part D drugs obtained out-of-network unless the plan's out-of-network coverage policy applies. Costs paid for or reimbursed to an enrollee by insurance, a group health plan, most government-funded health programs, or another third party, including Medicaid, State Children's Health Insurance Program, CHIP, federally qualified health centers, rural health clinics, patient assistance programs outside the Part D benefit, TRICARE, Federal Employees Health Benefits Program, Black Lung funds, and other health reimbursement arrangements. Costs for drugs purchased outside the United States are not included in the TROOP. Any manufacturer payments made under manufacturer discount programs are not included in the troop. So let's look at an example. Mr. Bingham takes blood pressure medication. He requested a formulary exception, which was denied by his plan. He decided to continue taking the non-formulary prescription and pay for it out of pocket. The amounts Mr. Bingham pays for the drug do not account towards his deductible or other out-of-pocket costs. Example 2, Mrs. Howard has terrible seasonal allergies. To address her allergies, she takes a prescription drug that is on the formulary and supplements it with over-the-counter drugs to address specific symptoms such as a runny nose. Only the amount that Mrs. Howard pays for her prescription allergy medication counts towards her true out-of-pocket costs. Her costs for over-the-counter drugs do not count towards the troop. Pharmacy networks. Part D coverage is generally provided through contracted pharmacies in the Part D plan service area, except that private fee-for-service plans are not required to use a pharmacy network, but may voluntarily choose to have one. Network pharmacies include retail pharmacies, long-term care pharmacies, and may also include mail order pharmacy. Within their networks, Part D plans may designate some pharmacies as preferred pharmacy, that lower levels of cost sharing than apply at other network pharmacies. So there would be a preferred cost sharing for the member at the preferred pharmacy and a standard cost sharing at other network pharmacies. Enrollees are generally required to fill prescriptions for covered drugs at network pharmacies. Under certain circumstances, enrollees may fill prescriptions for covered drugs at out-of-network, non-network pharmacies, but possibly at a higher price. For example, if the enrollee has an illness or loses a drug while traveling outside the service area, or if the circumstances result in limited drug access through an in-network pharmacy. Part D premiums and late enrollment penalties. Part D plans may charge a premium. Typically, a higher premium means lower out-of-pocket costs for the plan. Part D enrollees have 3 options for paying their Part D premium: an automatic electronic monthly mechanism such as withdrawal from their checking or savings bank account, or automatic charge against their credit or debit card. Direct monthly billing, automatic deduction from their monthly Social Security benefit check. Typically, it takes 2 to 3 months for Social Security withholding to begin or end. When withholding begins, it will be for 2 to 3 months of the premium owed. Generally, the beneficiary must stay with the premium payment option they choose for the entire year. If an enrollee does not choose an option, the beneficiary will be billed by the plan monthly. Non-Medicare insurers are required to notify beneficiaries annually whether or not the prescription drug coverage they have is credible. That is, coverage that expects to pay on average at least as much as Medicare standard Part D coverage expects to pay. Beneficiaries may have to pay a monthly premium penalty to join a Part D plan if they do not have credible coverage, they do not enroll when first eligible for Part D. There have been at least 63 continuous days from following a beneficiary's initial enrollment period for Part D, during which the beneficiary did not have Part D or other coverage. It's also an instance where the individual will have a late enrollment penalty if they go longer than 63 continuous days without a credible Part D plan. The penalty will be 1% of the national average beneficiary premium for each month the beneficiary did not have the Part D or credible coverage. The penalty is in effect for as long as the beneficiary has Medicare prescription drug coverage. Beneficiaries who qualify for low-income subsidy are not subject to the late enrollment penalty. Let's look at some examples. Mr. Russell first became eligible for Part D on December 1, 2023. He did not sign up and he has not had credible drug coverage. He wishes to obtain drug coverage during the annual enrollment period to be effective on January 1, 2025. He's not LIS eligible. Mr. Russell will have to pay a penalty of 13% of the national average, 1% for every month he did not have credible coverage for every month that he stays covered under a Part D plan. Ms. Smith lost her credible drug coverage that her employer provided when she retired. She signed up for Part D with an effective date of 60 days after the date she lost her coverage. She will not be eligible because she signed up before the 63 days. Part D drug management tools and formulary requirements. In addition to formulary and cost-sharing tiers, Part D plans use a variety of prescription drug benefit management tools, including step therapy, which requires enrollees to try one or more similar low-cost drugs before stepping up to the higher-cost drug. Prior authorization, which requires the doctor to contact the plan and request authorization before the plan will cover the prescription. The doctor must show the plan that the drug is medically necessary for it to be covered. Quantity limits. For safety and cost reasons, Part D sponsors may limit the amount of certain prescription drugs that are covered over a specified period. Substitution. Part D sponsors may substitute generic drugs for brand name drugs if the generic drug has the same or lower cost sharing and certain conditions are met. Comprehensive Addiction and Recovery Act programs. Plans may impose certain limitations on the prescribers or the pharmacies that a beneficiary can use to manage utilization for those who are at risk of misusing or abusing frequently abused drugs such as opioids. Plan D sponsors must provide coverage of a one-time temporary supply of non-formulary drugs or Part D drugs that are on a sponsor's formulary but require prior authorization, step therapy, or are subject to a quantity limit that is not safety-based to the following individuals taking such drugs. Beneficiaries initially enrolling in Part D, beneficiaries switching plans, current enrollees affected by certain formulary changes other than allowable substitutes of a generic drug for brand name drugs. This coverage is known as a transition refill. Beneficiaries eligible for transition refills must receive coverage for at least 1 month unless a lower amount was prescribed of their non-formulary drugs during the first 90 days after their enrollment, after their plan switch, or after a formulary change. The transition refills are only for drugs that the beneficiary is already taking. They do not apply to new prescriptions. During the transition period, the Part D plan does not apply to prior authorization, non-safety-based quantity limits, or step therapy rules. The enrollee and their physician may request an exception to the Part D plan's formulary to continue coverage of the non-formulary drug, or can transition to a formulary drug. Medicare prescription payment plan. Part D sponsors are required to provide all Part D enrollees the option to pay their cost-sharing amounts, including any deductibles, copays, or coinsurance, in monthly amounts spread out over the plan year, instead of paying them in full at the point of service at the pharmacy. Part D enrollees may opt into the Medicare prescription payment plan at the beginning of the year or at any point during the year. Part D enrollees who choose to participate in the program pay nothing at the point of service, but are billed each month by the plan. Monthly payments do not start until the beneficiary opts into the program and first incurs out-of-pocket costs for covered Part D drugs. The amount that the Part D sponsor bills the enrollee for a month under the program cannot exceed a maximum monthly cap calculated based on each enrollee's cost and the point in the plan year in which the enrollee enrolled in the plan. The monthly cap varies from month to month. Opting into the program will not affect how a Part D enrollee moves through the phases of the Part D benefit, that is the deductible, the initial coverage period, and the catastrophic coverage, or what counts towards their true out-of-pocket costs. While this program is available to any Part D enrollee, those incurring high out-of-pocket costs earlier in the plan year are generally more likely to benefit. Part D enrollees with low to moderate recurring out-of-pocket drug costs, such as maintenance drugs, whose annual costs are not expected to exceed the $2,000 or the $2,100 for 2026, are not likely to benefit from the Medicare prescription payment plan because their costs are already distributed evenly throughout the year. Enrollees can opt out of the program at any time. However, they will continue to be billed monthly for any cost-sharing amounts that they still owe. Failure to pay the monthly billed amount will result in disenrollment from the program, but not the plan, after a specified grace period. However, the Part D sponsor will continue to bill amounts owed under the program in monthly amounts. The sponsor may also offer the beneficiary the option to repay the full outstanding amount in a lump sum. Once a beneficiary leaves the program, they must resume paying their out-of-pocket cost sharing at the point of service. Enrollee rights. Enrollees have a right to request a determination of whether the plan will cover a drug determination. They also have the right to appeal adverse coverage decisions, including decisions about tiering or formulary exception requests. Part D plan sponsors must provide access via a secure website or secure email address on the website for enrollees to quickly request a coverage determination or appeal a coverage decision. Plan sponsors must also require network pharmacies to provide enrollees with a printed notice with the plan's toll-free number and website for requesting coverage determination. Requesting exceptions for drugs. Enrollees have the right to request coverage of a drug that is not on the plan's formulary or to request exceptions from plan rules such as prior authorization, step therapy, or quantity limits. Such requests are known as formulary exception requests. Enrollees also have a right to request coverage of formulary drugs at a less costly formulary tier. This is known as a tiering exception. Exception requests must be accompanied by a supporting statement by a physician or other prescriber explaining why the exception is necessary. A standard form is available on Part D plan websites for enrollees to request a coverage determination, including a formulary or tiering exception. A physician or other prescriber may also request a tiering or formulary discretion exception. Beneficiaries may file complaints about their Part D plan or about their pharmacies. These complaints are known as grievances. Grievances include complaints about issues such as pharmacy wait times, a plan's failure to mail a beneficiary requested material, or the length of hold time on the plan customer service line. Grievances do not include complaints about a sponsor's refusal to cover a drug or approve an exception. Beneficiaries must resolve those issues through the appeal process. Part D assistance programs. Medicaid, of course, is where beneficiaries with limited income and resources are encouraged to apply for low income subsidy, but that's through actually Social Security Administration, SSA.gov, and beneficiaries can apply at any time. If beneficiaries apply to the state Medicaid office for Part D help, the state Medicaid office also will check for eligibility for low income assistance programs. To get help with their prescription drugs, they can also call SSA.gov or apply online at SSA.gov. After SSA or the state approves an application for extra help, it is effective the first day of the month in which the individual applied. Certain individuals automatically qualify for extra help. Individuals automatically qualify for extra help if they have Medicare and meet any of these conditions. They have full Medicaid, they get help from their state Medicaid program, paying their Part B premium in a Medicare savings program. They get supplemental security income, SSI benefits. Medicare mails these individuals a purple letter to let them know they automatically qualify. They should keep this letter for their records. They do not need to apply for extra help if they get this letter. If a beneficiary has limited income and resources, they may apply for a low-income subsidy to cover all or part of their Part D plan premium and cost sharing. To qualify for low-income subsidy in 2025, the beneficiary income may not exceed 150% of the federal poverty level. The federal poverty level varies geographically. In addition, beneficiary resources may not exceed the published limit. The resources counted towards the limit include bank accounts, stocks, bonds, and other liquid resources that beneficiaries can easily or readily convert to cash within 20 days, and real estate that is not the primary residence. Based on 2025's federal poverty level, income limits are as follows. 48 states and DC Annually, 23,475 individual, 31,725 couple. Alaska is higher, and so is no, Hawaii is higher than the other 48 states, but those two are different. CMS publishes the resource limits for each year in the late fall of the previous year. For 2025, beneficiaries' resources may not exceed 16,100 individual, 32,130 for couple. These limits are increased by $1,500 per person if the beneficiary notifies Social Security Administration that they expect to use some of their resources for burial expenses. Individuals with limited income. For 2026, individuals who qualify for full low-income subsidy and are full benefit dual eligibles, FBDEs, with income at or below 100% of the federal poverty level and resources below the applicable threshold have a zero deductible and cost sharing of a maximum of $1.60 for generic drugs and $4.90 for all other drugs. If they qualify for full LIS and are also full benefit dual eligibles with income over 100% and resources below the applicable threshold, their maximum cost for out of pocket would be zero for the deductible and $5.10 for generics and $12.65 for other drugs. If they are eligible for low income subsidy but not eligible for the full benefit dual eligible, then those people would pay a maximum of $5.10 for the generic drugs and a maximum of $12.65 for other drugs. State pharmaceutical assistance programs. Some pharmaceutical manufacturers operate programs that assist low-income individuals. Some states have assistance programs designed specifically for their residents. Some programs are qualified state pharmaceutical assistance programs that counts towards the troop, and some do not count towards the troop. Becoming familiar with your state's program will allow you to help a beneficiary address cost sharing for their prescriptions. Medicare's limited income newly eligible transition program. The LINET program provides temporary Medicare Part D coverage to people with low income and Medicare who are not already enrolled in a Medicare drug plan. LINET provides temporary Part D coverage to the following: full benefit dual eligibles and SSI only beneficiaries on a retroactive basis up to 36 months in the past. It also offers temporary coverage to low-income subsidy eligible beneficiaries at the pharmacy counter and up to 30 days in the past. If a beneficiary paid for prescription drugs out of pocket before they joined a Medicare drug plan, but after they qualified for both Medicare and Medicaid or SSI, they may be able to get money back for those costs. All LINET application forms can be accessed at cms.gov/Medicare enrollment-renewal /Part D plans, low income subsidy, Medicare limited income net program. I would suggest you take a picture of this screen because that's a long web address. I'll leave it there for a second while I take just a swallow of water. Part D and other coverage. Employer union and other coverage of drugs. Employer or union coverage. Employers, unions will notify their employees of whether their non-Medicare prescription drug coverage is credible. Coverage on the average covers at least as much as Medicare Standard Part D covers. That's a credible plan. And they will get an annual statement if the plan is credible. If coverage is credible and a beneficiary keeps it, then the beneficiary will not incur a premium penalty later if they drop or lose the employer coverage and join a Part D plan within 63 days. If the coverage is not credible, the beneficiary will need to enroll in a Medicare Part D plan during their initial eligibility period to avoid the late enrollment penalty. If the beneficiary has credible drug coverage through TRICARE, the VA, or the federal employee plan, they can compare that coverage with available Part D plans to decide whether to enroll in a Part D plan. The beneficiary should check with their employer or union before making changes to their employer union coverage. If a beneficiary drops employer union prescription drug coverage, they may not be able to get it back. They may also lose health coverage. There will be no late enrollment penalty if the beneficiary retires or otherwise loses employer union credible coverage and joins a Medicare Part D plan or otherwise obtains credible coverage within 63 days. When a Medicaid beneficiary becomes eligible for Medicare, then Medicare instead of Medicaid covers the Part D drugs once the beneficiary is enrolled in a Part D plan. If Medicaid beneficiaries don't choose a plan, Medicare will select one for them. More information can be gathered at medicare.gov, the Medicare and You Handbook, and also your guide to Medicare prescription drug coverage. Okay. Everybody's still here? It's so quiet when I'm doing this and nobody's saying anything but me.
Yes.
It seems so strange.
Yes.
So I'm going to tell you, my voice over these nights and days that I've been working as well, my voice is tending to wane. So at this point, because some of the carriers are open, Aetna is open, Devoted is open, you can go through either one of those and get your discount so that you can go ahead and get AHIP and you can catch up to the practice test in module 3 by just going through. So I'm not going to read the practice questions.
Why not? I like that.
I know you do. Well, I mean, I can put them up there if somebody else wants to read them. I need to save my voice.
Oh, I understand.
Okay. Thank you for understanding. You're the only one that wanted it, it seems anyway. Thank you all for being here. Any questions? Any comments? Anything?
Thank
You're
you.
welcome, Frazier.
Thank
You're
you.
welcome.
Thank
You're
you.
welcome. You're so welcome. See you tomorrow night. Now we've already gone past halfway, so we're good to go. We're getting there. Thank you.
Mm.
See you tomorrow.
All right, thank you.
Good night.
Good night.
Good night.